Let us continue. There are a few more. Medullary carcinoma of the thyroid. It occurs in around 5% of the thyroid malignancy and arises from the parafollicular. Take note, it's the parafollicular, not the follicular thyroid. C-cells secrete calcitonin that functions to lower the serum calcium level. Most occur sporadically. Patient often presents with a neck mass that may be associated with a palpable cervical lymph node. So its metastasis is by lymph node. What other carcinoma of the thyroid has lymph node metastasis? Yes, it's the papillary. Local pain or aching is more common, and local invasion may produce symptoms of dysphagia, dyspnea, and dysphonia. So take note, this one has more common local invasion. And as most of the thyroid malignancy are asymptomatic, this one is symptomatic. Distant blood-borne metastasis to the liver, bone, frequently osteoblastic, and lung occurs later in the disease. And female ones, again, is more common at 1.5:1 ratio. Most are between ages 50 to 60 years of age. A picture of the pathologic findings in medullary tumor. 80% is sporadic cases, multicentric in familial cases, about 90% are bilateral. Tumors are composed of sheet of infiltrating neoplastic cells separated by collagen and amyloids. Take note, there are collagens and amyloids. By the way, where is that Samoma body findings? That's in papillary, correct. Diagnosis established by history, physical examination, and increased serum calcitonin or CEA level. Fine needle aspiration cytology of the thyroid mass can also be used for diagnosis. As compared to the follicular, fine needle aspiration cannot be used because we need an invasion. This one can identify medullary CA. Treatment is total thyroidectomy, and as much as possible, we want to get them at an early stage. Tumor larger than 1.5 cm should undergo ipsilateral prophylactic modified radical neck dissection. Okay, that's for treatment. Let's pass that one. Here is the usual survival. For papillary, it has a very good survival. Also for follicular. But when it comes to medullary, it gradually decreases as stage by stage. And the stage 4 medullary is only approximately 24% in its 5-year survival. Last is the anaplastic carcinoma. It accounts for approximately 1%. It's a very rare thyroid malignancy. However, it is the most aggressive. Once again, women are more commonly affected, usually on the 8 decades of life. Dysphonia, dysphagia, dyspnea are common because invasion is very common. Tumor is large and may be fixed to the surrounding structures. Lymph nodes are usually palpable at presentation, and diagnosis is confirmed by fine needle aspiration. It reveals a characteristic giant multinucleated cells. Treatment. This tumor is one of the most aggressive. As mentioned, few patients survive 6 months and beyond, so it is a supportive treatment. All forms of treatment have been disappointing, so you support the airway, you give pain medications for painful symptoms, combined radiation and chemotherapy in an adjuvant setting. The patient with resected disease has been associated with a little prolonged survival. Tracheostomy may be needed to alleviate airway obstruction as mentioned. Metastatic carcinoma, the thyroid gland is a rare site. Although if there is a metastasis, resection of the thyroid, usually lobectomy may be helpful. Depends on what is the status of the primary tumor. So that's all for thyroid. Now let's go for the parathyroid. Thank you very much.